What's going on, ladies and gentlemen? Welcome back. Today's episode is going to be brought to you by Mystery Ranch, built for the mission. And if you're not rocking a Mystery Ranch Fireline backpack, well, you're doing it wrong. Yeah, your back probably hurts like a lot. But aside from the most well-built, the most badass, and the most comfortable Fireline packs out there, they make a ton of other stuff. But it's up to you to go check them out. So go over to www.mysteryranch.com and check out all of their load-bearing essentials. And hell, while you're at it, might as well check out the Backbone series. And if you guys don't know what that is, well, you're in for a little bit of a treat. So the Backbone series is a series of stories about wildland firefighting from you folks directly out there on the front lines of the fire line. Yeah, it's pretty awesome. And yeah, I just want to give a special shout out to Mystery Ranch because they've also opened up the Backbone Scholarship Series. So if you got a compelling story or something epic to say, shed some light on what goes on the fire line, well, head over to www.mysteryranch.com and check out the Backbone series. Submit your story, and if you're chosen, well, bang, there you go. You get a $1,000 scholarship. It's pretty cool. It's exclusively available for the men and women that go above and beyond in the off season. You and I know that, well, classes aren't cheap. Medical training isn't cheap. None of it's cheap, and you got to keep it going. So what a better way to do it than through a scholarship. So while you're at it, go over there, check it out, submit your story, www.mysteryranch.com. Check it out. The Anchor Point Podcast is also going to be brought to you by our premier coffee sponsor, and that is none other than Hot Shot Brewery. It's kick-ass coffee for a kick-ass cause, and a portion of the proceeds will always go back to the Wildland Firefighter Foundation. Sup, Burke? You're doing some amazing work over there. Keep it up. But aside from kick-ass coffee for kick-ass causes, they make a ton of other stuff. They make a full line of apparel to help represent that wildland firefighting culture. It's pretty awesome. And they make all the tools of the trade to get your morning started off right. So if you guys are in the need for some kick-ass tools, coffee, or apparel, go over to www.hotshotbrewing.com and check it out. And while you're at it, go over there and check out the little section that says TAPPS, and that stands for the Anchor Point Podcast. Yeah, it's going to be awesome because they support the Anchor Point Podcast by slinging our merch. So if you want to get your hands on one of those Band of Brothers tees or one of those Fire Fiend tees, I highly suggest you go over there and check it out. Once again, that is www.hotshotbrewing.com. The Anchor Point Podcast would also like to give a quick little shout out to our buddy Booze over at the ASS Movement. And if you guys don't know what the ASS Movement is, well, it's an acronym, and it stands for the Anti-Surface Shitting Movement. It is the finest in poo-bearing propaganda. Hell, even Steve Rinella himself said that surface shitters are akin to tweakers or something along the lines. I'm paraphrasing, but it's a problem that needs to stop. So if you want to help spread the word about burying your turds, go over to www.thefirewild.com and check out the ASS Movement. And check this out. Listeners to this podcast can get 10% off site-wide on their order. Ooh, how do you do that? Well, it's easy. Go over to that website, www.thefirewild.com. Check out the ASS Movement, add some stuff to your cart, and at the checkout, enter the code AnchorPointASS10 for 10% off your entire purchase. Once again, if you want the best in poo-bearing propaganda, go over to the ASS Movement and check it out. And last but not least, the Anchor Point Podcast is going to be brought to you by the Smoky Generation, also known as the American Wildfire Experience. And if you guys don't know what that is, well, I highly suggest going over there and checking it out over at www.wildfireexperience.org because it is a humongous and ever-growing, pretty much monthly, daily, I don't even know at this point, but there's a hell of a lot of stories over there. But it is a digital archive of stories about wildland firefighting dating all the way back to the 1940s. It is freaking awesome. Not only that, but Bethany also has a scholarship opportunity out there for you folks in the field. So if you are a blogger, a writer, a photographer, a cinematographer, anybody who's telling the story of wildland fire, go over to www.wildfireexperience and check out the Smoky Generation grants. It's freaking awesome. Yeah, opportunities there for you. So go over there. Once again, www.wildfireexperience.org and check it out. Bethany, you have a kick-ass organization over there. Keep it up. views and opinions of this podcast do not reflect the views and opinions of the United States government, the Department of the Interior, the Department of Defense, the Department of Agriculture, the United States Forest Service, the Bureau of Land Management, National Park Service, the Bureau of Indian Affairs, or any private, municipal, county, or state firefighting organization, any law enforcement agency, any medical provider, or any contractor employed by any federal agency. What's going on, ladies and gentlemen? Welcome back. Hope everybody's doing well. It is Dirty August, and it keeps getting dirtier and dirtier and dirtier. So I hope everybody's doing well. And if you happen to get off the line for a couple of days, maybe 3 days, if you're lucky, well, I would do you do yourself some favors and maybe set up an appointment with a clinician. Reason being is because you can establish that relationship and that rapport with them for when the off season hits, and you're already going to be set up. So doing yourself some favors. But yeah, with that being said, definitely stay safe out there, and especially pay attention to this episode because there's some tasty little tidbits. And we're going to be talking about heat injuries, which it is August. It's hotter than hell out there. We're going to be talking about Rhabdo, and we're going to be talking about what a EMS medical director does. Yeah, it's pretty awesome. So, ladies and gentlemen, I'd like to introduce my good friend, Dr. Timothy Durkin. Welcome to the Anchor Point. All right, ladies and gentlemen, welcome back to another episode of the Anchor Point Podcast. Today on the show, I've got my good friend, Timothy Durkin. Mr. Durkin, what's going on, man? How you doing?
I'm good. Great to be here. Excited to talk about some medical stuff. And I think you wanted to talk about Rhabdo. It's a fun topic.
Yeah. The capital.
Yeah, I'm excited. So yeah, we're going to get down to it.
Nice. So tell us a little bit about yourself. What's the story behind Mr. Timothy here?
Yeah, sure. So I am a physician. I am board certified in both emergency and sports medicine, which is a little bit uncommon. There's only a little bit more than 200 of us nationally that are boarded in both those specialties. And then I've got a pretty strong interest in backcountry and wilderness medicine and rescue medicine and things like that. So, which is kind of how you and I got kind of in touch and so forth, because that interest has led me to get involved as local medical director for the San Juan National Forest and some of the firefighting and EMS activities that happen on the forest. Among, I guess that's one of 5 other jobs that I have. So, yeah. Anyway, so a lot of different interests, but really like to talk about things that are kind of at the intersection of emergency and critical care and sports medicine and outdoor and wilderness medicine and that, have some direct, and then kind of see what we can do to boil it down that's directly applicable to folks actually doing work outside. So.
Nice. So it's probably reasonable to assume that you are an avid outdoorsman considering your passion in, austere and remote medicine? Yeah, for sure.
My wife and I moved from Albuquerque to Southwest Colorado in 2015. And so we're super fortunate to live here. And I think my favorite probably thing to do is ski tour and ski in the backcountry. But we, my wife's a big mountain biker, so I try to, keep up with her, and that's kind of a struggle because she's better than I am. But yeah, I mean, it's amazing to live in Southwest Colorado and, get out on the water, go hiking, all the things. It's amazing. So yeah, for sure. We love it.
Nice. It's a beautiful place down there in Southwest Colorado. And you, are you out of what is that? It says San Juan. So what is that town down there? I can't remember it. It's right on the border of New Mexico and
Durango.
Durango, yes. Yeah. It was like right on my tip of my tongue.
I live in Durango. And so, yeah, the Columbine district is based here in Durango. And then they have some facilities in Bayfield. And then we have the Pagosa district over in Pagosa. and then the Dolores district, which is kind of half between Dolores and Cortez in there.
Nice. Right on. So life of a medical director. Now, you operate a interagency medical direction for the EMS program for wildland fire, essentially. So how the heck do you get into that? What is life like in the day of a medical director?
Yeah, for sure. So there's a couple layers to that. So how I got plugged in with the San Juan, I've been super involved with a couple of the search and rescue teams here locally. And there were a couple folks that were involved with both the fire program on the forest and then also with at least tangentially involved with search and rescue, and so kind of was aware of kind of some of the stuff I'd been doing with the search and rescue team and things like that. So I'm actually the first medical director that the San Juan has ever had. So they, have been, I guess, kind of wanting, or, so I've heard, but, yeah, so I'm the first. And so, basically they asked me to do it. And I said, yes. So as a medical director, I think my role is basically to support the EMS professionals that are out caring for patients. And that's has kind of a unique twist on it with the Forest Service. And so first off, I just have to say, I'm not, and obviously you have the disclaimer at the start of the podcast, but my other day job is also a federal employment gig. And I'm probably the least experienced and newest person as far as medical directors in the interagency EMS program. So, I'll just kind of caveat what I say with that this is not official whatever. But so the way the program is structured with some of the smaller EMS programs at the Forest, because there's we roughly have about 15 EMTs, give or take, on the San Juan, and then to pretty much everybody is affiliated with the fire program, and then we have one paramedic who's a seasonal hire, and so kind of my role is basically just to support them. And so that kind of comes into a couple different things. So one is training and kind of compliance stuff, and making sure that, particularly as folks deploy on the fires or move around or aren't on federal land, that we're complying, with whatever it is that we need to do. And then supporting them in terms of training and, those kind of resources. And then we've also just, with actually having some programmatic direction around the forest, that's allowed us to really kind of move towards some standardization of equipment and making sure that everybody's got the right equipment and it's been checked, relatively periodically, that things, because fire apparatus gets out in the heat, and there's a lot of medical gear that, if you just leave it in a compartment on a piece of apparatus over time, it's just going to degrade.
Oh, yeah.
And so just making sure that, folks have the physical tools to do their job, and then trying to support with some training. And then, towards the end of the season, kind of looking back at, incidents and charts and, where are there opportunities for improvement, or does that lead us to say hey, this is a great topic that we could train on and things like that. But I mean, so that's kind of the nuts and bolts of what a medical director does. And then with that is, or kind of the whole reason you would have a physician medical director is to make sure that, if you took an EMT class 5, 10 or more years ago, or, 2 weeks ago, whatever, maybe some of the things that you were taught are not current with modern medical science. And so trying to provide, that oversight to make sure that what we're doing medically is correct with what we know to be the best things for the patient in 2021.
So you're best
trying to carry that forward. Yeah.
Yeah. I'm sorry. I didn't mean to interrupt you, but like your evidence-based medicines that are most current and up to date. It's like the age old question about the tourniquet, the great tourniquet debate, right? So it's clarifying things like that and informing your EMTs, AMTs, and your paramedics out in the field who are in these conditions the correct way and the most up-to-date protocols.
Yeah, for sure. And then kind of interfacing with, what's going on with the national program. And again, I'm super green to all of it. But everybody I've worked with on, as far as other medical directors or some of the admin folks at the national level with the program, super nice people, very concerned about making sure that we're doing the right thing, that we're getting people the right resources, and just very focused on progress and improvement. So it's been a good thing to be involved in. It's exciting.
Nice. Yeah. You mentioned something pretty important about having the right equipment, especially out there in the field, especially the conditions that we work in. That's like super important because not only do you have to have the right equipment, but it has to be standardized in placement kind of almost. So like it's well marked enough in these apparatus, these fire apparatus, to where everybody knows where it is, because the EMT may not necessarily be the closest one to the apparatus. So that's important stuff.
Yeah, 100%.
Yeah. Now, so medical direction as far as like protocols, do you guys have anything special in your neck of the woods as far as advanced protocols or expanded scope or anything like that?
So the way that the interagency program, and interagency in this case being the Forest Service, is kind of dovetailed in with the National Park Service, is basically right now using the, the FM54, I believe it is. It's the NPS protocols. They're a few years old. The physicians of the program are actively working to revise those programs, revise the protocols. So, so as far as like anything special that we're doing in the San Juan that's like different from the national protocols, with me kind of coming on board just right at the beginning of fire season, and what I learned really quickly, not having a strong background in wildland fire, is trying to make some major programmatic movement in mid to late March is kind of a non-starter. And so, because my Chris, my main program coordinator, he's on the hot shots. They were on their first deployment, like third or fourth week of March. So, we're kind of making, I think my main goal for this year was to make sure we had decent gear for everybody to get started with. And then, kind of we're sort of strategizing, if that's a word, for the fall, kind of trying to, get set for some training and things like that, at least for the folks that are not going to be seasonal, that'll be around this fall. So, so just trying to do it. The other thing is, for the smaller programs, like a large national park that has, many patient encounters, and they might have like a couple of ambulances and, full-time paramedics and things like that. Those medical director positions are paid. They're a federal contract. But for, a smaller effort like what we have on the San Juans, where, probably, less than a couple dozen documented patient encounters over a season, and a small number of personnel, none of whom EMS is really their, front and center, the only thing they do. Then actually I'm a volunteer. I'm actually a public lands volunteer. And then they're kind enough to, I get kind of an honorarium when I come over and do training and things like that. Which, for the amount of extent of effort is okay. I'd love to be able to do more, but, like I said, I have, 4 other jobs. So, you kind of do what you can within the constraints of the resources that exist. But I think that segues nicely into, some of the stuff I've heard you talk about both on Instagram or some of the other podcasts is, some of the greater conversation around, compensation and looking at, what is appropriate for the effort and the dedication and the technical skills, that are required of our wildland firefighters. And so, I think one thing that should be part of that conversation is the firefighters who are the dual role EMTs, and making sure that they're getting, some incentive, that they're getting either a differential or that they're getting, a training allowance. Because right now that's kind of a hit or miss issue, forest to forest. We've had really, supportive leadership on San Juan for the first year to give us a nice EMS budget to kind of get things up and running. And there are some things I'd like to do with training and having some more resources for that. But, as you likely know, it's an investment of both time and money. You're probably at least $2,500 to go get your EMT. And then, if your employer isn't supporting you to get your mandatory Con Ed you need every year and providing some incentive, either some greater career path or some differential or something like that, it gets really hard to maintain those professional credentials. So I think, and I appreciate you giving me kind of a platform to advocate for the EMTs, not just here in Colorado, but around the nation, and just seeing if as while this is on the agenda, that maybe we can get some resources and some incentives to kind of make that better for folks.
Oh, absolutely. And like you said it right there yourself, it was said perfectly. But a lot of times I come from a very fortunate background, as the district that I worked for, they offered incentives to go get your EMT basic, right? My EMT advance came out of my own pocket, but like you said, it's a lot of money, each part of that program, whatever step you're in of it and in the program, whether it be basic or advanced, a lot of that money comes out of your own pocket. So yeah, we absolutely need qualified medical professionals and qualified medical personnel on the line, because at the end of the day, there's no one else out there besides us typically. And your definitive care is 3, 4, 5 hours away. So you need to have pretty dialed in EMTs and medics or EMT advances all the way from your baseline medical care, your first responder, all the way up to your paramedics. And you got to have a lot of planning in place for an incident within an incident. So yeah, I would like to definitely see some more incentives nationwide for these folks to get their EMS quals going.
Yeah, I think, and as you've touched on, I mean, there's most of the mandate for, unlike the Park Service that has a mandate to go out and help the public as they get into misadventure in our national parks. The Forest Service does not really have a mandate to go out and assist the public, which is not to say that if you get hurt in front of a Park Service person, a Forest Service person, they're clearly going to, do what they can for you, but they don't, that's the volunteer search and rescue team here that goes out if you have a misadventure in the San Juan, generally as a member of the public. But it kind of speaks to, now a lot of the EMTs and fire, some of them will work ski patrol in the winter and get some patient care exposure in that realm. But I think a small, and it seems to be kind of similar to what I've heard from other areas, is a lot of the EMTs working in fire don't have a lot of high volume EMS experience. And so I think, again, that comes back to that need for investment in training, investment in simulation, investment in scenarios and things like that. That it's, and I think you've talked about this as well. It's not just, okay, I have this card from the registry in my parket, I'm good to go. There's also like, do I have the physical tools to be able to provide some meaningful intervention? And then, all these skills, all this knowledge is highly perishable. And so just making sure that there's that, investment in current skills and things like that, to make sure it all comes together. Because as you just touched on, I mean, we have a couple nice search and rescue teams that work in the San Juan here on the volunteer side from, under the county sheriff, that I've been privileged to work with. But, we don't have NOMEX. We're not red carded. So if it's a fire operation, it's all on what's there. And so, and then, with that, then, it's not just the medical piece, as you kind of touched on as well. There's also the extrication piece, and you can't land a helicopter in every place possible. Even when it was funny. I come from the SAR background of like, okay, this is a wilderness area. We're going to call the Forest Service and get permission to land the helicopter and things like that. And just hearing the first time I heard a phrase, "We'll just cut an LZ," I was like, that's an interesting perspective. And so, but even given that, I mean, there's places where, the land that's underneath the trees is not flat, and, you cannot the helicopter can't interact with that ground. So that implies, you're going to need to affect some degree of ground movement and ropes and things like that. And so that's another area where I think there's, training opportunities and investment opportunities and stuff like that. So, and to see, again, that's something there's probably opportunities for standardization and investment in nationally. So, yeah.
Yeah, that's one of those things too to touch on is like what I meant by, have a plan, have a system of redundancy with your planning for when an incident happens. Because like you said, I mean, we can't just land a helicopter everywhere. We are beholden to the weather conditions. So if you're socked in with smoke, guess what? You're not going to get a short haul or a hoist ship in there, and it's going to be a long pack out. So you absolutely need to be dialed in stabilizing your patient before you start extricating them off the hill. Because if you don't, well, it's going to be a bad time. So
yeah, for sure.
Yeah,
for sure.
But that and just like common injuries, let's go over some common injuries and incidents that you've seen on the line. Like, what is our most common things? I would assume like your slips, trips, and falls, broken stuff, broken ankles, broken limbs, maybe heat injuries, and cardiovascular. I'd want to say.
Yeah, so in terms of things I've seen on the fire line, I'm not even red carded yet. I'm hoping to test out my field day like later this year, and kind of get a little bit more out there as far as on the fire side. But from talking to folks, I think we had our first prescribed burn of the season. We did have a firefighter that got some second degree burns on that prescribed fire. The total surface area on those burns was thankfully very small. So that person did not need to be admitted to the hospital, thankfully. So that was good. But I mean, that's always a risk, with fire for sure. And, when I was a paramedic before med school, I came from like an urban, fire EMS background, structural department, things like that. So, that's always kind of a front and center concern. But I think, not being able to like quote the stats off the top of my head, but I mean, yeah, you're right on. The slip, trips, and falls, the orthopedic type injuries, I mean, that's like half of it right there. And then, yeah, heat and, maybe not at the point of like full on heat stroke, but, some degree of like heat injury, heat exhaustion, things like that. That's definitely a big one. And, definitely done some education with like the HeliTech crew here and some of the other crews about some of that stuff, because I think that's another one that's ripe with misunderstanding, is the whole heat illness thing. So those are big ones. And then, yeah, it was interesting to hear, as I was kind of going around doing some meet and greet with some of the staff around the forest, hearing some stories of, they happened to run into some hiker who then collapsed and had a full cardiac arrest just right where this crew happened to be doing some maintenance stuff. And they ended up kind of defibrillating this guy with an AED. And absent any other resource or anything like that, the guy, woke up after getting defibrillated, and he was actually able to walk to a medical helicopter, which was kind of an interesting story. So
after a full on MI, huh?
Yeah. Well, wow. I mean, it sounded like. So there are other things besides a occlusive myocardial infarction, heart attack that'll give you a sudden cardiac arrest. And so I would, if the guy wakes up and after getting buzzed and stuff, doesn't have crushing chest pain or things like that, that he feels pretty good, then it kind of implies a primary arrhythmia and things like that. So, that guy, if he woke up that quick, I mean, he should do fine. He'll probably need a defibrillator put in his chest, but, kind of an interesting story. So, the fire world is again, still, it's not like unheard of coming from like, a structural and EMS kind of background, but, the wildland side is a whole other thing. And so I've been really grateful for, my coordinator and our AD paramedic who've been really like gracious about educating and integrating me. So it's been good. It's been good. Yeah.
You're smiling at the paramedic thing. Is the paramedic on staff there? Are they pretty salty?
No, that's not the adjective I would use for this person. No, he's been great. He's really quite fitted to the role. He's got some high volume EMS experience that he got after being in fire for a while, and then ski patrols and does a decent amount of patient care in the winter, and just kind of has a really good integration of both the fire and the medicine part of it. So it's he's been a great resource for me and goes around and does a lot of education with the crews and stuff like that. So Mike, if you're listening, thank you.
Yeah, those paramedics though, there's a lot to learn from paramedics, especially with people with paramedics with a lot of street medicine experience. And reason why I say that is because they're great. They're like almost intuitive of just looking at a patient and knowing what's wrong with very little diagnostic tools almost. I mean, yeah, you have to do your differentials, of course, and you have to figure out what the hell is going on, but they're very good at like recognizing things from afar, and they're even probably better at improvising with what they have as far as the tools go, at least.
Yeah, I think, it seems to me from what I've seen and the experience of others, there, comes a point where you've seen, in the like thousands of patients numbers in your career, where you begin to assimilate information in almost like a pre-conscious type way. And, I'm sure Malcolm Gladwell or someone could articulate this in a much more eloquent way than I am right now. But, I think there's a lot of, just as like a super experienced person who's got, 15, 20 years in fire can kind of look around and just kind of sniff a change in the wind and have some intuitive sense that things are about to change or what's going to happen. There's that, at the point where you have, tens of thousands of hours of experience in some field of human endeavor, you start to get pretty functional at it, I would say. So, and then, as you get, you pair that with more education and you tend to get more capable. So, yeah.
Oh yeah. It's pretty crazy. Like, especially, like a big city EMS, like a busy EMS called area. Yeah, you get those hours and you get them quick. But yeah, that years of experience definitely adds up into being a kick-ass paramedic. It's cool, man. It's cool to watch that process and just to learn and chat with them and learn everything you can. Just soak everything they have in like a sponge, man. It's cool. Yeah.
Ah, for sure.
Yeah. So we kind of brushed on heat injury right there. And I know there's been a lot of concentration on the topic of heat injuries lately. I know it's kind of one of those moving targets as far as what to do out in the field for a heat injury, but let's break it down from your perspective.
Wow. Okay. So I've, yeah. All right. That's fine. So, the life threat is heat stroke. And so what is heat stroke? Heat stroke is a condition where the body's core temperature has risen to the point where you have failure of temperature regulation. And at that point, the proteins or just the tissue in both your brain and your liver begin to cook. And I'm not using entirely metaphorically, just like if we put a piece of meat on a grill and the tissues of that piece of meat will begin to change under the heat in a way that can't be reversed. That is what happens in the body during heat stroke. And which then implies what the treatment is, which is we need to cool that person as quickly and as aggressively as we possibly can. And so with that, that's kind of the one paragraph summary. So what does a heat stroke look like? Well, it looks like brain dysfunction. So things like unsteady walking, suddenly labile mood, irritability, perhaps a seizure, perhaps a collapse, any instance of brain dysfunction brain dysfunction in the setting of heat stress. And for some circumstance and some people, there are plenty of cases of heat stroke when it wasn't super hot out. People either had some medical issue or some innate susceptibility, or they were engaged in really hard exercise. And, because you've got heat from the environment and then you have heat you generate in your body as you move. And so you got to have the radar up for it. And then the other kind of diagnostic pearl is that only a rectal temperature is going to help you in a heat stroke situation. All the other ones are going to mislead you, give you false low numbers. There was on one of the sports medicine podcasts, there was a great case. One of the docs presented of working at a marathon where a person came in who's just babbling nonsense, clearly altered. Got an oral temperature at the triage of this race medical tent and was triaged as hypothermic. And then come to find out, when they got a rectal temp, the person was absolutely having heat stroke. And so they needed to be cooled. So, and, there's a lot of this, you'll see these different infographics and things like that where they'll talk about like hot, dry skin, and that's all garbage. And so, there's the Jordan McNair case, which was a football fatality. They had a third party investigator, and it well documented that his skin was cold and wet. And so you can't really rely on those type of physical signs. Heat stroke, nasty stuff. And you don't have to have heat exhaustion before you can have a heat stroke. This can happen quickly if you're working very hard in the heat. And then treatment. And particularly you asked about how that goes in the field. So again, our objective is to cool that person as aggressively as we possibly can and as quickly as we can, because it's an area under the curve problem. So the higher their temp is for the longer period of time, the more damaged this person's body is going to be. But if we can cool these people aggressively within 30 minutes of collapse or 30 minutes of symptoms, then the survival and functional recovery rate is about as close to 100% as anything we have in medicine. But it's a scary disease because it's one of the few things that can kill a young, healthy person really quickly. So how do you affect aggressive cooling in the field? So probably a lot of older, people that went through EMT kind of and paramedic and like the time frame I did, or even more recently, kind of an old talk of, well, you want to put some cold packs in the groin or on the neck and things like that. That's garbage. So there was a great paper done by a guy I used to work with at my ER in Albuquerque named John Lissaway. And when he was doing his wilderness medicine fellowship at Stanford, they actually studied that issue. And so there's actually better heat transfer if you use the palms and the soles, because there's actually capillaries and vessel beds and things like that there, than there are at the groin and the neck. But we really need to be cooling the whole body in these people, because only whole body cooling will cool a person fast enough for the best outcome. And there's you'll hear these, people talk about like, oh, you don't want to cool them too quickly, you're going to make them sick or something like that. Garbage.
It's all BS,
cool them as quickly as you can. What's that?
It's all BS.
Yeah. So there's just, again, it's like rife with misinformation. So you need to cool them as aggressively as possible so that their brain and their liver won't be toast. So how can we do this in the field? Well, the gold standard is a tub that we can immerse people in that's filled with ice water. And then you want to agitate that water to get kind of more movement and more cooling. And so, if you told me, hey, it's going to be 110 degrees and, Dr. Durkin, come out and help us set up, the medical unit at this fire, then I'm going to go to the agricultural store and I'm going to buy a couple Rubbermaid 100-gallon stock tanks and have a bunch of ice handy so that I can do that. And the 100-gallon agricultural stock tanks are great because they're deep enough you can submerge an adult up to their neck and their whole body is in the water, but they're short enough that you can't like extend out to the point where your head can go underneath the water and you could drown. So that is the gold standard, is the 100-gallon stock tank with a bunch of ice water. Recognizing that is logistically challenging. So there's a couple other alternatives. So and I'll move from we just talked about the best, and now we'll kind of talk about progressively less ideal options.
Kind of walk it back.
And so, what's that?
I said kind of walk it back from best case scenario to worst.
Yeah, for sure. So then the next thing, if you don't have the 100-gallon stock tank, is tarp cooling. And so what you do is you get yourself a big tarp and maybe 4 people. And if the tarp is big enough, you basically can put the person in it and a bunch of water. And again, you can imagine the tarp is kind of on a slant with the feet lower than the head because you don't want to drown the person. And you've got some ice and some water, and the person in the tarp and the people on the left and the people on the right kind of take turns to kind of jostle the water around and things like that. And that's been well described as a successful and effective cooling method. The next kind of step as we progress towards greater austerity would be to do sheet cooling. And so this is where you have a cooler that has bed sheets in it, just flat sheets, either from the hospital or the thrift store or Walmart, wherever you can get them. And those are sitting folded in a cooler of ice water. And so now you take this and and in all these circumstances, you're removing all this person's clothing and so forth to cool them quicker. And so you put these ice water soaked sheets over the person, and now you have kind of whole body cold water, and you have some degree of evaporative cooling that occurs. And if you have a salvage fan, a ventilation fan, whatever you've got to try to increase the air movement, that one will obviously work better if you're dealing with lower humidities. But it's certainly been used in high humidity. The military has had good success using that kind of at more remote, training sites and things like that. The military's done some really good work and research around this. So if you can't do that, now you're starting to get into some difficulty where perhaps your treatment effectiveness and your survivability is kind of starting to degrade. As we touched on, if we only have a limited amount of things we can cool and so forth, then the palms of the hands and the soles of the feet have much more vascular access and vascular exchange and capillaries and stuff than the neck and the groin and stuff like that. So a similar study that Dr. Lissaway and the folks at Stanford did was looking at the little chemical heat packs, cold packs that a lot of folks have in their medical kit that, you squeeze it and then it gets a little colder and things like that. The amount of thermal transfer that can occur from one of those is pretty not enough.
Almost negligent.
You really need ice in some quantity. Absent ice, maybe you have an engine that has 300 gallons of not ice water, but it's not, probably not super hot water, and it's probably cooler than the patient. So, dousing, kind of continually getting water flowing over that person, to cool them. That's certainly been one way that's been, I talked with some folks in the Austin region who've had success doing that. So another thing that I've thought about that I've not had a chance to play with yet, and I'm really curious to do that, is to see if we can use a fire shelter like a tarp, and fill that up with water and see how, if the stitching would let water leak out, which a little bit would be fine. But, and I know somebody's going to be like, oh, you got to save your fire shelter for a burn over. But, I would say the fire shelter exists to save the firefighter's life. And so if a firefighter has a heat stroke, they are dying. And so we should use all the tools available to save their life. Similarly, some EMS agencies have used a body bag to affect, similar to a tarp cooling type situation, fill it up with ice and water and things like that. So that's also in the doable range. But so that's kind of a quick overview of some heat stroke stuff.
Yeah, I like the improvisation there. That's actually a pretty good idea. I don't know if a fire shelter is waterproof or not.
I would, and if somebody has one that's like, the packaging is damaged, but the shelter itself seems to be intact, that's not, or maybe it's past date or something that they, can't use, I'd pay you to ship it to me so I could play around with it. So, yeah.
There we go. So one last question about the heat injury thing too. And now we've all heard this. Now there's a rumor out there, and I don't know if it's medically accurate. So what better a person to answer this question than a doctor? But the susceptibility to heat injury after you've had an initial heat injury. Now, are you more susceptible to subsequent heat injuries after your first one?
Yes, /probably /maybe. So there's a couple different parts to that. So in the weeks to maybe months after someone has a heat stroke, then they have impaired thermoregulation. And so they are more susceptible kind of moving forward. How long that lasts? There's debate, and that probably depends on, how quickly they were cooled, how severely they were injured, things like that. As I think we can, probably there's some understanding of, there is inherent risk factors that you might have. Like, for instance, there's certain medications that make people more susceptible to heat injury, both, things you might take just today because you feel bad, or things you might take every day for some medical problems. So, if you're still on that medicine, then that risk is going to carry forward. If you are overweight, then that impairs your ability to transfer heat out of your body. So that's going to be an enduring risk. There's definitely some period of enhanced risk there after a heat stroke. In terms of a heat exhaustion type situation, probably, like, I'm a person that's fairly heat sensitive, even, when I try to acclimate and things like that. So I think that kind of carries forward. But there's also a fatigability issue here. Like, if you were out and took a lot of heat stress yesterday, and now you're going to go out and it's going to be even hotter and there's more fire activity and you're going to take more heat stress, you're much more at risk than somebody who just is showing up well rested and so forth. There's also decent data that says if you're not, well rested, like you haven't gotten a good solid 8 hours of quality sleep, then you're more at risk for heat injury for sure. So yes, probably not necessarily a permanent thing, but whatever you had before you got heat injured still exists, and then you definitely need to have an appropriate recovery period before you're back out, in the heat stress.
I got you.
Good question.
Yeah, it's I guess there's some cumulative effects there. It's just like cumulative fatigue. It all just kind of stacks on itself eventually. But also, a lot of people out there associate heat with rhabdo, and this is kind of one of those things that are like one of those intersecting topics, I guess you could say. I don't know if that's accurate or not. It could be related.
Yeah, so there's a couple. There's a reason those topics can get conflated or kind of lumped together sometimes in sort of a not ideal way that promotes great understanding. So if you have a heat stroke, then you will have blood markers of rhabdomyolysis present in your blood in large amounts. And likely you have, in many cases, some degree of muscle damage in the setting of a heat stroke. But you can think of it in that case as a side effect of the heat stroke. Because what's happening in a heat stroke is, and we should probably back up and talk about rhabdo and what it is, kind of and why it happens. But the side effect of the heat stroke is that the muscles are metabolically ramped up and probably depleting some energy supplies. And that leads to increased membrane permeability and cell damage and things like that. And then also, most folks who have a heat stroke will tend to collapse onto the ground. And if you are lying on the ground for a long period of time, then that will give you rhabdomyolysis from a pressure injury. And then also with that, then, if it's hot enough that, probably a younger healthy person has collapsed from heat stroke, then that probably implies that the ground they fell onto is also quite hot. And then there could be a direct thermal or even a burn injury to the muscles at that point. So there's kind of a lot of things that are going on that can kind of make those bad actors show up at the same time. But they're from an origin perspective, they're not the same. They're not coming from the same issue.
Okay. Well, since we're on the topic, let's get into the Rhabdo thing and kind of explain it.
I'm stoked to talk about this. Okay, so rhabdomyolysis, fancy way of saying muscle tissue injury and death. Okay, so what happens? So the muscle takes an insult. So could come from one of several things. Could be inflammation or infection. So inflammation is like your immune system is not acting properly and decides to attack the muscles. Infection, most viral illnesses that are going to make a person sick. I think we've all had a fever and felt muscle aches. That is the virus inflaming your muscles and causing reasonably a low-grade rhabdomyolysis. If you then go out and try to work hard on the fire line, you're asking for problems. We'll come back to that. So that's kind of one thing. You can have a direct injury, i.e., a tree fell on my thigh and I have this horrible bruise that goes down to the bone. It's a direct muscle injury. And then the most, kind of where we worry about this the most is the energy depletion inside the muscle. And so all the cells in the body have a gradient of things on the outside of the cell and things on the inside of the cell. To maintain that gradient, you're consuming energy all the time. There's your cells need that. And, when that happens, the cells are not, when that stops happening, the cells aren't alive. And, if that happens to enough of your cells, probably you're not alive. So if you deplete the energy within your muscle cells so severely that gradient can't be maintained, then the cells start to fall apart and break down. And the things that are inside the cells come out of the cells and they go into your bloodstream and then they find their way to your kidneys and they begin to damage your kidneys. And then this causes fluid shifts in your body, which put further stress on the kidneys. And then that also causes inflammation kind of generally in the body, which doesn't help the fluid shift problem. And so that's kind of really where we start to really worry about rhabdo, because as we'll talk about coming up, just because you have blood tests that look like rhabdo, sometimes that's not necessarily inherently bad. But with the point where it starts to trash your kidneys, then you're in trouble and you need help. So that's kind of a very basic overview of kind of what we're talking about. And so where I think most people get interested in rhabdo from a injury on the fireground perspective that doesn't involve, a tree fell on me or something like that. Or a training injury, a PT injury or gym injury or things like that, is that energy depletion issue. And so if you work out hard, excessively hard compared to your prior level of conditioning or your level of nutrition and hydration and things like that, then you can get to a point where you deplete the energy in your muscle cells to the point where they will begin to have that failure of the cell walls. And then you're in trouble. Then you've got some degree of rhabdo. And so then why does this happen? So in terms of the excess exercise issue, there's a couple factors in play. If you're coming into hard exercise, like really aggressive or extreme exercise, or even moderate exercise, if you're like a sedentary person, you're totally coming off the couch, then you can get into trouble. And if we look at, some of the cases that have come out of like the Lesson Learned Center and the information like the Interagency Fire Center has put out, most of these injuries are happening first day of fire camp or within first 3 weeks of coming on the job for seasonals. And so, and that's the same thing we see in cases in collegiate sports where we've got a lot of good data. It's that first practice of the season. It's coming back after break. And, the coach wants to set a tone, or the crew boss wants to show everybody how hardcore this crew is. And that's where we can really get into trouble. And so, because what happens if you're not trained, we think about like, what are the adaptations that happen in your muscles when you work out and get fit? Well, you get more capillaries to deliver energy into the muscle. You get better enzyme activity to kind of recycle and process waste and get more energy ready inside the cell and things like that. So if we haven't kind of readied that muscle for that level of activity, then we can easily overcome its ability to regenerate energy itself. And then another thing, and this was, kind of implicated in a lot of like the, like 10 years ago, CrossFit got a lot of bad rap for some rhabdo issues. And I think it comes down to a programming decision when you're looking at like making a workout, is if you're putting in a lot of eccentric training, that's known to be a higher risk factor. And so what do we mean by eccentric training? So eccentric training is training where we're basically emphasizing the negative phase. We're lengthening the muscle with resistance. So everybody knows, like, I do a curl and I'm concentric because the muscle's getting smaller. But if I still have weight and I'm like trying to do a 10 count with this, then that's eccentric. And, if you do too much of that too soon, if you're not ready for it, that's a good way to give yourself rhabdo. If you're doing it dosed correctly, then that is a good training method to build muscle and strength endurance. But that is an advanced training progression as you're trying to get stronger and things like that. And then the other thing to know, as far as in that energy sphere, that issue with making sure the cell has enough energy, is that when the muscle is contracted strongly, the blood vessels in the muscle get kind of smushed down. And so there's not new blood coming into the muscle if your muscle is contracted. So, if you can imagine like, Brandon, you and I are going to go do a pull-up contest, and, nobody can let go and nobody can, stop making effort. And we do that for a long time. Well, that's a good way to get rhabdo in your forearms, because you're not giving an opportunity for new blood and energy to come into the muscle and waste products to leave the muscle. So that's kind of some of the stuff as far as, training decisions, or what we call in sports medicine, like training errors.
I've definitely made mine. That's for sure. Yeah.
I mean, I think a lot of us, kind of on our fitness journey have wanted to be further along than we are. And that's there's nothing free, and you've got to put the work in over the time. And it's going to take time. So,
oh yeah. Well, that's another thing.
So those are the big ones. Yeah, for sure.
Sorry about that. Yeah, that's another thing too, is like that whole training error, and the crew boss maybe with a little bit too much gusto. Well, that was me at one point in my fire career. And it was exactly that. Pull-ups, very eccentric motions, very eccentric exercises. And unfortunately, I had to learn the hard, difficult lesson of what it's like to injure one of my crew members. If they're listening to this, they know exactly who they are. I just want to say I'm so fucking sorry for what happened. It was one of those things. And I didn't know if there was some fatigue. They're in shape. They never quit. They never gave a sign of like, I'm done, and it was one of those hard lessons that unfortunately I had to learn for myself. And unfortunately I injured somebody, and it's completely accidental, but I feel terrible about that.
Yeah, I think you touched on something important, though, is that person who has that never quit mentality. Because that also, I think, is definitely, what I'll just term as like a pathologic level of motivation. And, if you can motivate someone at a pathologically high level to exercise, that's when people get injured, whether it's rhabdo or other types of injuries. There was a case series of, a cluster of, basically like a whole group of ROTC candidates or ROTC students at a given college all got rhabdo because they were given this like really hardcore workout and said, whoever does best at this workout is going to get to pick their job. And whoever doesn't do good, in terms of the military, like, are you going to get, the high speed, cool job that you want, or are you going to get what nobody else wants? And that was going to be determined largely based on their performance on this fitness test. And so that was able to motivate, these soon to be young Army officers to all injure themselves. So, that could come from, an authority figure trying to drive something, using physical training as punishment. Or maybe it comes from the fire that, hey, if we don't get over this ridge to the safe zone, we're all going to die. So, that's pretty strong. That's pretty motivating, right?
Oh, yeah.
But that's a situation where certainly people can push. And in that circumstance, we can treat rhabdo, much easier than we can treat being burned to death. So, run away from the fire, but at the same time, just understanding that that's a high level of motivation. So, yeah.
Yeah, it's one of those high levels of motivation. And that's the thing, too, is the never quit mentality. I think a lot of, tactical athletes, such as fire, police, military, they're just geared that way. It's part of the culture.
Yeah, we see that some. I think, we also see, folks that aren't as committed to fitness, which I'd rather see somebody, going hard than doing nothing at all. But I think you need to understand that, exercise and training is essential to your health, but like anything else, drugs, food, exercise needs to be dosed appropriately to provide health benefits and not injure you.
Definitely got to titrate that one to effect. And like I said, I learned my lesson the hard way. But so rhabdo is one of those, it's not necessarily nebulous, but the signs and symptoms, I guess, of it are a little bit, because the person that my only encounter with this subject is the person was, they looked like they were physically ill with like food poisoning. That's what it looked like. So what are some signs and symptoms to watch out for?
Yeah, absolutely. So, and as you've kind of touched on, there's no perfect constellation of symptoms. So I think it requires a little bit of self-awareness to see, hey, this is beyond something I've routinely experienced. So what are some things, if your urine is changing abnormally, like, looks like Coca-Cola or looks abnormally dark, that's a pretty good sign. It's time to go to the hospital. And if that happens just once, but then your next urination looks okay, you still need to go to the hospital, because myoglobin is actually pretty transient in your blood. And so, you're still, just because it's like, oh, I peed again, it looks better. You need to go to the hospital. Disproportionate soreness, to the point where like you're, it's waking you up. I think if, that'd probably be a good one to seek care over. If any of your muscles or a group of muscles were to lose function or power, like you're half as strong as you usually are, or maybe less, or you can't, you literally can't use that. Like I can't grip a coffee cup because my forearms are so, overtaxed, then that's probably a pretty good one. Tense, palpable, uncomfortable swelling in any group of muscles. If your kidneys start to hurt, on your back at the behind your ribs there, if those are actually painful, somebody who's just generally ill, that, maybe they went hard on the fire line, whatever, looking bad, maybe they're puking, maybe they have diarrhea, that person needs to be medically evaluated. Maybe it's rhabdo, maybe it's something totally unrelated, but what you're describing, that person needs to be looked at. And, certainly anybody that has volume depletion, like they can't keep fluids down, or they can't keep up with their diarrhea, things like that. I mean, now what might be a mild situation that your body could totally just get over really quick is now going to become something where your kidneys are going to be really taking a bad hit because you don't have the fluids in your body to manage it. So yeah, so those are kind of the ones I would look out for.
Gotcha. And now what about diagnosis? So we talked about signs and symptoms. What about the actual methodology, I guess, if you will, to diagnosing?
This is where it gets murky for us as the clinicians on the hospital side. And this is something where, having the additional training in sports medicine, I feel like really advantaged over some of my colleagues in the emergency department. Because it helps you contextualize this a little bit. And what do I mean by that? So, there's papers where they looked at blood tests. Well, I'm jumping ahead of myself. So, okay, you go into the hospital and you say, my muscles don't work and they hurt really bad and my pee is discolored. I think I have rhabdo. Okay, great. So we're going to do a blood test called CK, or creatine kinase, which is an enzyme that's in a lot of body tissues. It's mostly in muscle. So, if your muscles are damaged and their interior contents are leaking out, then we will see large quantities of this in your blood. This is where things get a little weird. So depending on whose medical research, medical paper, medical opinion you read, and the diagnosis of rhabdo is established if your CK level is 1.5 times the normal, 2 times the normal, 5 times the normal, greater than 10,000, greater than 20,000, or greater than 50,000. So there is not wide consensus in the medical community over at what level of CK do you have rhabdo? Because there's always a little bit of CK in your blood all the time in normal, healthy people. Yeah. That's normal. It's a natural enzyme that's just in your body. So then you're kind of left with, well, what do we do with this? And so to contextualize that in the sports medicine world, folks that have finished a marathon or an ultra marathon might have they're happy. They don't feel bad. They're celebrating that they finished their big race they've been training for, might have CK levels of 30,000. If you come into a clinic or an ER off the fire line and say, I feel bad, and have a CK of 30,000, any doctor in their right mind is going to admit you to the hospital for IV fluids. So there's kind of an issue of context there. And, and maybe we're being more conservative than we have to be, but, wouldn't you rather just deal with a night in the hospital than a lifetime of dialysis? So that's kind of what we have to weigh. And so you've got to look at, and then if you're trying to make a decision, if I'm trying to make a decision clinically, I might consider, is this person able to drink? Here in the ER, they're pounding beverages, they're able to hydrate on their own, or they have a queasy stomach and I'm worried about their ability to hydrate, without an IV. Do they have some sign of kidney injury or other medical issues happening on their blood tests? Then that gives us a much lower threshold to admit that person to the hospital. And so I think particularly if clinicians aren't well versed in this area, then I think a lot of folks might be conservative. But that's okay. That's okay. And so, so there's definitely, so I guess to summarize, there's not 100% consensus on what the threshold is, to really be concerned.
Okay. So there's not really like you said, a threshold to diagnose 100% rhabdo. It's kind of a moving target, if you will.
Yes and no, but I think you could say, like, if you had muscle pain and a CK greater than 50,000, that was the highest recommended standard in a paper I saw. So that means that all the other people that said, well, it's only twice normal or 10,000 or 20,000, Well, they're all in agreement. So I think just the higher that number goes, what's the like 9 out of 10 doctors agree, right? So the higher that number goes, the more and more clinicians are going to be concerned. And then recognizing that CK number probably won't peak until about 72 hours post injury. So even though you're low, the night after your, hard day of work, then it's not unreasonable to be conservative in the first 24 hours, because to some extent you might not know what's going to happen.
I gotcha. Now, how often do you think this condition goes unrecognized? Because I've seen a lot of folks out there just kind of like, oh, I'm just abnormally sore. Or it's nothing. I'll just brush it off. I think that rhabdo happens more often, whether it be a low or a medium grade of rhabdomyolysis. I think it happens more often than we give ourselves credit to finding out. So what's your thoughts on that?
You're probably right. I mean, I don't have data to kind of answer your question with any degree of authority, but I think that makes sense. If somebody is reasonable and self-aware and they, can't use their arms, then I think at that point, I would hope most reasonable people would seek some medical care, regardless of what the cause of that was. And there is, if I go run a mile at a light jog pace down the street and come back, I'll have some mild elevation in my CK most likely. But the question is the real question is, when does that become meaningful?
And everybody's different too.
Yeah, for sure. And so that becomes kind of a conundrum. But I think, again, if you want to look at your long-term life and health and enjoyment and things like that, maybe you can get through it, but your kidneys took a 10% hit. Well, that's going to show up in your blood pressure 5 years down the road. That's going to show up in your stroke risk and your heart attack risk and things like that. So, to talk about, and this is something I kind of have some strong feelings about, because so one of my other jobs is I do annual physicals for several fire departments here in Southwest Colorado, with a company out in Nevada called 1582, and we help small and mid-sized departments around the West with annual medical screenings for their firefighters. And so, as you start to study health among firefighters, anybody that works in emergency services has higher risks of cardiovascular disease than people of similar age and other occupations, higher risk of cancer, higher risk of lung disease. And firefighters are worse than police, worse than EMS workers, just because of all the garbage you have to breathe on the fire ground. And so I think, this tough guy attitude of I'm going to blow this off and truck on is not serving us well. And if you want to have success and longevity in your career and be able to perform on the fire ground and then get to a point where you can enjoy the retirement that you've earned, like you have to invest in your health and not be a knucklehead about this stuff. So it's tough. And, I can't tell you exactly what's what, but I would say I wish people would have a lower threshold to take care of their health in emergency services. Is kind of where I'd net out with that.
Yeah, and it makes a lot of sense because we're a very work hard, play hard kind of culture. And every time you do that, which is pretty much every day, just shaves a little bit of time off the your life and the quality of life that you're going to have later down the road. I mean, shit, if you look at it, most firefighters, wildland firefighters that do a full career, a vast majority of them have some sort of cardiovascular, some sort of lung issue, or they just have a massive MI 5 years after they retire. I mean, it sucks. But it's also you're kind of... And,
if maybe we can change the culture a little bit and, invest in your health because it's worth it and you're worth it, then maybe we can change that kind of moving forward. I'd like to hope.
Oh yeah, that's up.
I think we've all kind of seen and heard that, or even folks that are still on the job that don't even make it to retirement. And, it's sad to see.
It is sad to see. And that's the thing is like, we need to change that culture. And that's, the root of any good public health program is baseline education. Think about the future, not in the moment so much. I mean, you still got to think about it in the moment, of course, but think about the future, think about what you're doing to your body and take the proper steps to mitigate some of these risk factors.
100%.
Oh yeah.
Yeah. 100%.
So sorry, got down a rabbit hole there.
Yeah, for sure. No, I mean, but it's I don't know. It's one I get excited to soapbox about.
No, so, I mean, soapbox away.
You've got several, we've hit like, 3 of my like things that get the vein to pop up in my forehead topics, heat stroke, rhabdo, firefighter wellness. Like, yeah, we're making the rounds here. So it's good.
So back to the rhabdo thing. Now, as far as treatment goes, what is like the most effective treatment that's out there for rhabdo? Is it just fluids, like you were saying, intravenous fluids?
Yeah, for sure. So standard of care is basically just aggressive hydration to like in terms of what we're going to do in medical unit, hospital, whatever, is fluids. So you need to basically flush that garbage out of the kidneys. So before that happens, recognizing that you're overtaxed and kind of throttling back or stopping work, hydrate, eat, get cooled off, whatever, kind of, that's probably the initial thing before you come to see me. And then, at the point where you get into, the advanced care arena, fluids are kind of the mainstay. There are different people that have advocated for, different additives we can put in the IV fluid, that might help to different things. None of that's really been well studied, so nobody really can advocate it for, I can't say it's bad. I can't say, or it's good. It's just, there's not really, it hasn't been looked at enough to say that that's a supported practice. There is some expert opinion that, and this is probably directly applicable for any of the ALS providers that are listening. But there is probably some expert opinion that we should be using, like, okay, you're a fireline paramedic, fireline AEMT, you're confronted with someone you think has rhabdo. We should probably be using LR on these people, not normal saline. And that's because the LR is a little more balanced and isn't gonna, it's not gonna promote so much acidosis into the kidney, which is at an acidotic state in the kidney is probably a lot of our problem. So, if you don't have a choice, then, and they're not orally hydrating and, they're presenting as fluid depleted, then, NS is probably preferable to nothing. And certainly we use that, has been used for quite a while. But if you have the option, I would choose LR for that patient. And then, also on the ALS side, you'd probably be, Wellser, grab the 12 lead. You're looking for hyperkalemia stigma there, not ischemic stuff, but hyperkalemic stuff. And then that's basically it, is to move them on to the hospital. We can trend some CKs. We can make sure their urine output is good and their kidneys are doing okay. And if they're not, then it's a temporary dialysis situation. They get the junk out of the blood, and then that will hopefully allow if that's done in time, the person can recover, their renal function. But, there is, and again, we don't really know these numbers, and it's probably different for everybody, but there is a tipping point between, at some point there's so much garbage in your blood and the kidneys are so, irritated by this that they're going to kind of shut down. And then that's where really, you're going to either be on dialysis for the rest of your life or you're going to die if you're not getting intervention. So, anyway, so it's not some magic wazoo thing that we have. It's mostly just hydrating and protecting the kidneys. The dialysis thing is pretty wazoo, in terms of we have this machine that replaces your organs, but most of the overwhelming majority of cases, hydration takes care of it. But, at the point where you're pushing a lot of fluids, you really need to be in the hospital because you got to make sure we're not like washing out your other electrolytes and things like that. So, yup.
I gotcha.
Yeah.
So no pasta water, huh? No pasta water. Just go straight for the lactated ringers.
Well, LR is still in that pasta water category for trauma. So, like crystalloids are not happy in trauma anymore. And, I think they probably never, well, really they never were, but, it's one of those things that took us a few years to A, figure out, and then B, let go of our old leaching ways. So, but LR being balanced is the way to go for this patient.
Copy that. And hopefully
versus the guy who got smashed or girl who got completely smashed by the giant tree who has a crushed pelvis and stuff. Like, they don't need crystalloids. They need evacuation, blood, and surgery. So, yeah.
Gotcha. Yeah, it's pretty wild, the new advancements that we've had as far as like protocols, I guess you could say, like getting away from the pasta water and just diluting what's already in the container. But yeah, it's interesting to see. That's for sure.
Yeah. And I think, as we start to get a next, because most of our technology now is, patch or sew up the holes, give blood, and then the body heals itself. But I think as we get into, another 10 to 20 years down the road, when we have actual, biologics that can, fill a wound cavity or things like that. I mean, there's, that'll be interesting to see where it goes. But yeah, no, we've come a long way. I mean, I just, can remember just, when I was a paramedic, like, oh yeah, I'll give everybody IV fluids. Like, we didn't help anybody. We were still doing that when I was an intern. And oh God, I mean, I won't, this isn't a medical focused podcast, like with the audience. So I'll spare you all the details, but like some of the complications of the aggressive IV fluid, without an emphasis on blood products, were just dreadful. I mean, just dreadful. Like, it was rough stuff to see. So yeah, just people like swollen up and not so good.
It's like you pump too much fluids in them, and now all of a sudden you have to give them Lasix to get the fluids out of them, and then find a balance.
Even
between.
you can't even do that because they're still inflamed and in a shock state, and so they're just horribly swollen or having other complications, and it just. Yeah, I mean, I'm glad we've moved past that era because it was we weren't doing anybody any favors.
No, so, the automatic 1,000 ml bolus of IV fluids that's definitely a thing of the past.
Oh, and you thank God, yeah, niche.
2 lines, give them the 16s, 2 bags.
Yeah, it's too much. So no good.
So now what about prevention of rhabdo? We've talked a lot about the signs, symptoms, the treatment.
Yeah.
What about prevention?
Yeah, for sure.
This seems like something that's...
So a couple things. So, and this kind of ties back to some other risk factors we haven't talked about. So if there are certain medications like that people take for cholesterol or some kind of heavier duty mental health medicines that put people at risk. So if you're on that sort of thing, talk to your doctor. You should know about that and kind of see if maybe can we switch gears to like another medicine, something like that. If alcohol is on some level toxic to muscles, and that effect probably lasts more than a few days. Like it might last as long as a week. So hard partying before hard work on the fire, like save that for after the hard work, right? Because that is an additional risk factor. And then, if you're sick, like if you're already ill, under the weather, things like that, like you're much at risk. So what else can you do to prevent it? We can steer clear of that stuff. The best thing is just to be conditioned, to be appropriately physically conditioned when you show up for work or when you show up for assignment or things like that, and avoiding, as we've already talked about, that pathologic motivation. You can't hydrate your way out of not getting rhabdo, but if you're significantly dehydrated, then you're at more risk because you're not going to have as much fluid in your blood to drive nutrients into your muscles and bring the waste out and things like that. So there's no benefit to overhydrating, but being dehydrating is no good. There was a case series that came out of college sports where they looked at a bunch of student athletes that got rhabdo after practice, and they noticed a trend where the athletes that had a protein smoothie after the workout were less likely to have rhabdo. That does not mean that a protein smoothie will reduce your risk of rhabdo. It might mean that the people that weren't going to get rhabdo were well enough to drink a shake, and the people that were going to get rhabdo were too nauseous to have a shake. We don't know. But, certainly in the long term, keeping your nutrition up is good for your health and probably would prevent that or reduce that kind of injury.
Okay. So
yeah,
majority of it is just being healthy and self-aware.
For sure. And just being appropriately conditioned and fit for the training loads and the workloads you're going to put on your body.
Okay. Well, there you go, ladies and gentlemen. Definitely avoid the damn alcohol.
I'm not advocating a teetotal position, but again, if you're going to go out and have to work really, really hard, then alcohol is not helping your preparation for that, nor is it helping your training. So, just be an adult and make adult decisions.
Yeah, no, that's that thing. There's a personal responsibility into, doing this job, act appropriately.
100%.
Oh, yeah. Well, damn, that's a big breakdown of the rhabdo and the heat injury illness realm. I love it, man. That was awesome. But
you kind of curveball me with the heel nose thing because
I'm sorry.
Fortunately, that's something I know something about. So it's kind of front and center here.
Right here.
Yeah.
Yeah. I didn't mean to curveball you, but I was like, I thought it would be like a good segue to differentiate between the two, because they're not necessarily, I guess, related. They can be, but not necessarily.
Yeah, for sure.
Gotcha.
For sure.
So one more question I wanted to ask you before you get out of here is I wanted to talk to you about your magazine, the article you wrote for Wilderness Medicine magazine, and the concussion review for the wilderness. That's pretty cool.
Yeah, for sure. And again, this is another thing where, just that intersection between emergency and sports and longer term care and prevention and, the emergencies, I don't know, it's stuff I really like. And where I did my sports medicine fellowship at UF, Go Gators, it's super, one of the things I think we were strong in a lot of things. It was a great program, but I think we really had a strong concussion program in terms of the education and the care we were providing folks at the program. So it's an area of interest, and it's something that a lot of, like, even as an emergency physician, before I kind of decided I wanted to take my career in the sports medicine direction and incorporate that into it, it's just not something that even as a physician you really have a lot of knowledge on. And so, as an emergency physician, you're very well trained in how to resuscitate people with critical brain injuries and protect their brain and, keep them alive and move them on to neurocritical or neurosurgical care and things like that. But as far as like, what do we do with these people who, you hit your head, you feel bad, you look bad, but you're not at the point where we need, a breathing tube and a CAT scanner and all this kind of stuff, and trying to figure out like, what do we do with those people and stuff like that. That's where I think there's some huge opportunities for everybody in EMS, I think, around the concussion space. So it's another topic I get. Man, you're like hitting all my like excitement topics tonight. So this is awesome.
You got some passion, man.
I actually have two friends that are involved with the WMS magazine, Dr. Seth Hawkins, who is the main editor, and then my buddy Mark Cassone, who I actually work with in my ER. And so he's one of the other editors and so forth. So they had, I guess Mark had hit me up about maybe doing an article on concussion. And so yeah, and it's a great topic. It was a well-received article. So I don't know, what can I tell you about the article or concussion, or what do we?
Oh, just some things that are in the article that we can apply to the wildfire realm. Like, say someone gets smacked in the head with a rock or a tree limb or something like that. Some of the takeaways from your article would probably be beneficial to for the folks.
For sure.
Read.
Okay. So the first thing, just like anything else, right? Okay. The first thing is like, is this safe? Are we going to be burned over? Or is like more things falling? Do we just need to get the hell out of here? Okay. So let's say we've checked that box. Then next thing is, okay, is there like huge open brain injury, bleeding, horribleness, airway? Okay, we've checked that box. The person's like awake. They're not bleeding. They're holding their head. They're kind of a little glassy eyed and they look a little unsteady on their feet. And so our ABCs, our scene safety, we've kind of run the box there. So now the next thing is like, we need to evaluate that person and we're looking for red flags of structural brain injuries. So things like a major trauma mechanism, like they fell off a cliff or, like the whole giant tree fell on them or, whatever. I think we all can kind of imagine what that is. So then other evidence of structural brain injury, someone who's getting worse with time, someone who is having persistent vomiting. Hopefully we don't have any elderly or small children out on the fire line, or people that are systemically anticoagulated, although maybe we do. So somebody who is on blood thinners, I'm going to kind of hit the alert button on that pretty soon. And so those are, some of the ones we hit on in the article and things like that. If you find physical exam evidence that, either you can feel like a crack in their skull or you can see like the battle sign or the raccoon eyes or things like that, evidence of a skull fracture or things like that. So those would all be kind of in your red flags for structural brain injury category. If you have that, then you have to kind of think like, oh, this person could have a brain like a bleeding inside their skull that could get worse with time. And, now it's time to do things like call a helicopter and go to the hospital really quickly and things like that. And, hopefully your med unit has done stuff like figure out like what hospital has neurosurgical capability versus which one doesn't and things like that. And, for somebody who's really kind of presenting, with a big head injury, then probably you want to just go back to the neurosurgical shop. Okay, so now we've ruled that out. And now we've kind of said, hey, we don't think this person has a structural brain injury, but we still have some concerns. So you can ask the person about symptoms of concussion, like do you have a headache? Do you feel nauseous? Does your neck hurt? Do you feel kind of blurry vision? Do lights and noise bother you? Do you feel foggy or slowed down? All those are concussion symptoms. Just as we've already kind of touched on, some people, and in my experience, particularly acutely concussed patients, will not want to be very forthcoming about their symptoms and they'll want to tough it out. And so that's where we're kind of observing the patient. And so observing them and see, can they not focus? Are they unusually irritable? Are they kind of sitting there holding their head going, no, I'm good, bro. Like clearly not, right? Okay. So observing the patient, that can give us maybe some objective evidence. And so that could be really helpful. And if if you find problems in any of those and somebody who just had a deceleration mechanism or a head injury or things like that, then that's a concussion. Okay. That's what it is. That's why the person feels bad, is we've injured their brain. And so, and I should also take this opportunity to say you don't have to hit your head to have a concussion. If you're, say, riding in a vehicle that suddenly has like a stop-start type thing or things like that, then you can jostle your brain around in the skull enough to give yourself or to get a concussion. Okay, so at the point where we've ruled out the red flags, they don't look bad. They're not holding their head. They don't look glassy-eyed. They say they feel good. They're denying the headache, the cognitive symptoms, things like that. Then you can function test their brain. And so that sounds really complicated, doesn't it? It's not. You're using your brain right now. So you make them use their brain. And so you can do simple things like read this work assignment, or, I'm going to say 175, you're going to say 571, and we'll go back and forth with a few of those Or you can have somebody do a simple task that should be fairly easy for them, like, go to a different talk group and channel on your radio, or, can you show me where we are on this map? Things like, or, can you, call your spouse on the phone? Something simple that this person should be able to do. And if they struggle to do these simple things, like they can't dial their phone, or they have to like squint, and you can tell they're rubbing their head because the activity, the additional cognitive load is straining their brain and provoking their symptoms, then again, boom, you've just established that they have concussion. And so that's kind of, how I approach it is you've got kind of your red flags, then you've got your kind of your symptoms and your overall appearance. And then if all that looks good, you can proceed with your function test. And then if the function test all looks good, they feel good, they look good, then you want to keep an eye on them, because they might present with some symptoms, few hours, tomorrow morning, whatever, and then at the point where you've established someone has a concussion, or you suspect that they have a concussion, that person needs to be removed from the fire line. People that have concussion have measurable deficits in their ability to visually track. They have problems with balance. They have problems with impulsivity, and they have problems with judgment. And so, you can imagine that if you're impaired in that way from a brain injury, this is not someone you want to be in difficult and dynamic terrain with. And so you got to get that person off the fire line. And not only are you preserving your own safety and the safety of others in that way, but also you're promoting their recovery and their ability to, work later in the season and things like that. Most, at least in the sports arena, if a giant boulder, smashes you on your head, hopefully you have a helmet, but, we get into like a little bit of a different realm. But in the sports world, 80% of these folks are going to be good by the 2-week mark, often sooner, if they're managed appropriately. So we know, and we were one of the sites for this study. It was out of a DoD grant that was done with a lot of the SEC schools. But we know that concussed folks that stay in the game, even if they don't have another injury, their recovery is longer and their symptoms are more severe. So if we can rest them for the rest of the day of the injury, then, or the remainder of the day of the injury, then their recovery will be quicker and their symptoms will be less severe. And then that kind of segues into this idea of like a second impact syndrome, or like, that kind of concern. There are a few cases out there of people that got a second, quote, minor head injury and then went on to have like much more severe symptoms. We would see that in concussion clinic, not like people dying or ending up in the hospital, but just people that have like much worse concussive symptoms and a more prolonged recovery with a second injury. But again, you don't have to get a second injury to get a prolonged recovery. Even just like more exertion, more work, being out in that, high cognitive demand environment, that's going to prolong your recovery. So it's a super, super interesting topic. And so, so that's kind of a quick overview on concussion. And then can I egregiously self-promote something?
Absolutely.
Okay, awesome. So if you would like to learn more about concussion and earn continuing education credits approved by the state of Colorado, myself and several friends have an education company called Base Medical. And so we mostly focus on wilderness first aid and wilderness first responder stuff, but we have a growing number, not a great number, but a growing number of standalone continuing ed modules for EMTs and paramedics. And we have one on our website called Brain Injury from the Sidelines to the Summits, which basically goes in much more depth of what we've just talked about. And you get, 45 minutes or an hour of Con Ed that, it's state approved. So registry will take it. And, I go on and on about this topic for a little bit longer. So if you need an hour of Con Ed and you want to learn more about concussion, check that out. So, yeah.
Nice. Well, cool. Yeah, definitely going to put some links in the show notes about that and see if anybody in the state of Colorado.
Yeah, I can send some stuff. Yeah.
Yeah, if anybody in the state of Colorado definitely needs some continuing education credits, well, that'd be an interesting topic.
Yeah, for sure. And you can map that into that like TB. Yeah, there's a couple NREMT core content areas you could map that into. So yeah. Anyway, so check it out if you need an hour con ed. My voice doesn't sound like, nails on a chalkboard. So.
You're good, man. You're good. So speaking
Awesome.
of that, where else can we find you?
Yeah. So let's see. So base medical. Yeah. If you're looking for, there's first aid, first responder training, maybe a little con ed. We also have, for anybody that does search and rescue stuff, we have a bunch of training for that on the website too, which is I'm pretty stoked about. I put a lot of that together. And then I'm on Instagram. So I am Colorado_rescue_doc. So Colorado Rescue Doc on Instagram. And then what else? I guess those are kind of the big things.
The two primaries.
Yeah.
No Twitter, no face page or Facebook.
I don't. I just Twitter's too crazy. I can't handle that.
I can't do it
much. Yeah, for sure. The links to a lot of that stuff, the article and the con ed and all that stuff. There's a link tree on my Instagram, so it's easy to find all that stuff. But yeah, I'll give you some links for the show notes too, so it'll be there. So yeah, awesome. Cool.
Yeah. Well, coming to the end of the show, I was like to give you the opportunity to give a shout out to a homie, a hero, mentor. Could be several. Take it away, man.
Yeah. Okay. So first people, going way back to when I was a volunteer paramedic in Maryland. Chris Tuzo and Todd Dolan were my paramedic preceptors, and they gave me a foundation in how to take care of sick people and kind of get ahead of people's physiology that I've carried forward my whole career. So, Chris, Todd, if you're out there, thanks guys. Next person I want to give a shout out to is Justin Spain. So Justin and I did volunteer mountain rescue together in Albuquerque, and Justin was an incredibly kind mentor and taught me basically the foundations of everything I know about rope rescue and things like that. And so he's a super solid guy, and I think he's a lieutenant or a captain in Albuquerque Fire now. And yeah, super solid guy, great teacher. And so that's great. And then the whole crew at University of Florida Sports Medicine, go Gators, chomp chomp, and miss everybody down there. But that fellowship was just awesome, and really learned a lot. And then I want to give a shout out to Chris Ives, who's my EMS coordinator on the San Juan Hotshots.
He's a good
and
dude.
Mike Fitcham, who is AD paramedic on the San Juan, who I'd be just lost without Mike's help. And so just some great folks I get to work with on the San Juan. So yeah, that's what I got.
Nice, man. Yeah, I know Chris. Chris is a good dude. He's actually been on the show. It's yeah.
Oh, no kidding. Okay, I didn't know that. All right, well, I'm gonna have to dig that episode up.
Yeah, he goes down to Mexico to go train some of the wildland firefighters down there. Basically, it's pretty awesome what he does in the off season.
That's amazing. Okay, I'll have to talk to him more about that. Yeah, I think they're all deployed up in Montana right now for a lot of the ongoing festivities. So
there's a lot of them.
Yeah.
That's for sure.
They've had a busy season for sure. Thankfully, not in my backyard, but well, they've had a lot of lightning starts around here, but thankfully nothing that went crazy big.
Yeah,
so,
nothing like the 416 fire a couple years ago.
Yeah, or the Missionary Ridge before that. Yeah, we're still dealing with mudslides from 416, and that's left quite a scar. But yeah, that was a lot of just seeing the impact of that and kind of wanting to be, a contributing member of the community. And that was a lot of the reason where I was like, yeah, I want to get plugged in with the Forest Service and be able to contribute. And, I think my wife and I are going to live here for a number of years more, and I don't think that's our last big wildfire. So I'd like to be able to contribute where I could. So yeah.
Nice. Yeah. Durango's a hell of a town. And yeah, thank you for doing what you're doing. I mean, this is important work, and we definitely need to expand our medical program and have the tools of the trade to get the job done right, especially out there in the middle of nowhere where it's very austere and very remote. And typically no one's really coming for you unless you're lucky.
Sure. Yeah. Very real. Very real.
It's real stuff. So once again, Dr. Durkin, really appreciate you being on the show,
Brandon,
man.
Thank you. Super fun.
Yeah.
Had a blast.
Well, hopefully we'll get you back on here soon. Talk some more medical nerdum.
I'm in. I'm way in.
Right on. Well, take care, man. We'll see you on the next one.
Have a great night.
See ya. There we go, ladies and gentlemen. Another episode of the Anchor Point Podcast is in the books with Doc Durkin. Dude, that was an awesome episode. And yeah, thank you for coming on the show. This is the first time we've had we've had several doctors on the show, but I guess from the related field that you're in, the emergency kind of thing. And it's pretty cool. Yeah, we definitely learned a lot about heat injuries, what you actually do for the interagency EMS program, as far as the medical director kind of thing. It's pretty awesome. And we also talked and covered a lot of subjects about Rhabdo, the all-elusive Rhabdo. Yeah. So, Doc Durkin, thank you so much for being on the show, man, and sharing your subject matter expertise. I definitely enjoyed it, and I hope we get you back on the show again. And yeah, you also had a publication in the Wilderness Medicine magazine, and it's about concussions in the wilderness. So if you guys want to read that, I'll drop some links in the show notes. But once again, man, thank you for being on the show. As for the rest of you, stay safe out there. And like I said on the intro of this show, definitely take some time and make some appointments if you can. And that way you can establish that rapport with your clinician. So stay safe out there, folks. Have a good one. Special shout out to our sponsors. We got Mystery Ranch. They make, obviously, the best damn packs in the game. So go over to www.mysteryranch.com and check it out for all of your load-bearing essentials. Mystery Ranch, built for the mission. We've got Hot Shot Brewery, purveyors of the most kick-ass coffee for the most kick-ass cause. They actually donate a portion, a rather sizable portion of their proceeds to the Wildland Firefighter Foundation. So go over to www.hotshotbrewing.com and check out their full selection. We've got the Ass Movement, the very best in poo-burying propaganda. Go over to www.thefirewild.com and check out the Ass Movement. And yeah, enter that code AnchorPointAss10 for 10% off your entire purchase. And last but not least, we have the Smoky Generation. Bethany, you have a kick-ass organization, and I love the stories that are coming out of the field from you folks in the field. It's pretty cool. It's epic. As for the rest of you, you guys and girls know the game. Have fun, be safe, stay savage, peace.